channel. I'm flabbergasted, to be honest, lost for words, and I just want to thank each and every single one of you who have watched and supported me throughout the years. So let's go on to the procedure now. It's a very difficult, challenging case of a patient who attended with extremely impacted earwax. It's squashed very deep in the ear, right against the eardrum. They performed the cardinal sin of using a Q-tip, also known as a cotton bud in the UK. It caused them so much distress that they've not been able to sleep. They visited their GP, who, so in the UK, up until about 18 months ago, primary care in the UK, so our GP centres, used to still offer ear irrigation. So I know that's very common in America still, but it's outdated in the UK. We don't really, now anyway, remove earwax by flushing water. I know in some parts of America you still do syringing with an old-fashioned metal syringe. That was banned from the UK, I think a decade or two ago, and it's replaced by irrigation, where a controlled flow of water is pumped into the ear. That can be done in several ways. You can use a foot pump, or sometimes you can regulate the flow using a dial on the machine, and it's similar to what the dentist used to rinse your mouth out. It comes with a nozzle, insert it into the ear, pump water into the ear at a more steady flow, so unlike the old metal syringe where you really siphon it into the ear, it's a lot safer. However, in the UK we don't even do that anymore, not least GPs don't offer it. I know a few audiologists still do. They're still not converted into the gold standard technique, which is microsuction, which is what we're performing. So anyway, so the GP, given how severe this case was, said, look, we're going to have to refer you to the hospital. Current waiting list unbelievable at the moment. You're looking 6 months to maybe a year, if not longer. However, the pain got that bad that the patient attended accident and emergency at the hospital yesterday, and obviously A&E, they don't remove earwax. And so the patient then found myself online and arranged an appointment. Upon attending, it was so painful, their ear, that they were actually holding the side of their face, which makes it really difficult because they're already experiencing otalgia. So otalgia is the medical name for ear pain, and in some way we're only going to be adding to that until we remove the wax, because I'm going into the ear, and as soon as we touched the surface of the wax, it was slightly uncomfortable for the patient. So it's a very tricky procedure. Now, although this is not keratosis obturans, the keratosis obturans is a plug of dead skin very deep in the ear immediately, and this plug of dead skin, it collects and grows. It's almost like a rubber ball, and it expands. And it can also, the expansion is so severe, it can actually start to expand the ear canal. So this is not, keratosis obturans is dead skin buildup. This is not dead skin, this is actually earwax, but nonetheless it felt as though it was like keratosis obturans. It was really large, and it's really tricky to remove, mainly because the patient's experiencing earache. So whenever we do a procedure, I don't want to put the patient under any pain. In the UK, audiologists are currently, at least, not allowed to use any local anaesthesia. ENT obviously can. They can inject lidocaine or behind the ear, or they can put some lidocaine solution, cream, drops into the ear. And in the worst case scenarios, I know some ENT that I've worked with, they've had no choice but to perform procedures like this under general anaesthetic, because it's just so painful for the patient. So I know sometimes I see comments like, oh, you're taking forever to do this, you don't know what you're doing. No, I do know what I'm doing. I just don't want to put my patient under any pain, and if it was your ear, I'm pretty sure you would appreciate that yourself. So we're just being very gentle and delicate. I'd rather spend an extra 5 to 10 minutes getting this out safely rather than causing the patient unnecessary excruciating pain, and they've already got earache. So this has been pushed in. Now, the metaphor or analogy I gave to the patient was, imagine you're on a beach, you've got a spade and bucket and the wet sand, and you're shoveling that wet sand into the bucket, and then you get the reverse of the spade and you start hammering it, squashing it in, impacting it inside the bucket. that's essentially what they've done with the Q-tip here. They've pushed it so deep and they've squashed this so much. It's a complete airtight seal. If I did a hearing test prior to removal, I'm pretty sure they would have had a severe to profound loss. So you're looking up to 70 to 100 decibel hearing loss here. It was that bad. So we're just using suction, and the ear hooks, it's supposed to be really, really careful with the ear hook. As soon as you make contact with this, it's, in some respects, you're pushing it, you're adding to the impaction like a cotton bud. So I'm just trying to disrupt the surface. I did try and get around the edge of the canal wall, but it's so impacted, and that's the bony part of the ear canal. You make contact with that bony part, it's really uncomfortable. So an ear hook, actually, although it did slice and dice a bit, it didn't remove the wax, but it did disrupt the surface. Now what I do, is a little tip for audiologists or clinical ear care specialists watching. In cases like this, I try to use the ear hook to remove the core, the midsection of the plug of wax. The reason for that is then I can then go on the periphery or against the canal walls and bring it inwards. And because the core's hollowed somewhat, there's no resistance. There's no wax in the middle of the plug that pushes the wax that I'm trying to bring in from the outside of the canal inwards. It gives less resistance there. So I kind of hollowed the middle out slightly, and then I'm trying to now bring the wax in from the outer part of the canal wall where it's completely pushed up against. I'll just use some olive oil drops here. Actually, I think it was maybe sodium bicarbonate drops that I used on this occasion. Like you can see, I'm just bringing it in. And because I've hollowed the core out, there's more flexibility, there's more manoeuvrability with this plug. And you just have to be patient sometimes. I was just kind of, over the last month or two, in my head, trying to calculate my average appointment time, or not so much appointment time, sometimes we talk to the patients, but procedure time. And I would say on average, and this is an average, I'm probably looking around, I would say 1.5 minutes, 2 minutes per ear. And that is an average. Sometimes I'm literally there for a few seconds, just suction it goes. So whenever I'm in the clinic room for with a patient more than about 15 minutes, my clinic manager and of the hair clinic, and also my business development manager for Clearwax, so they go by the names of Tracy and Dharma, they kind of know straight away, oh, this is a bit more trickier than the norm. And you can just see how it's like chewing gum as well. It's that compressed. It's like chewing gum. And I think the best analogy I can give was the one I gave earlier, like wet sand in a bucket, and it just squashed. And okay, with the bucket, it doesn't have, it's not going to be painful for the bucket, is it, if you're going to scoop it out? But this is someone's ear and they're already in pain. So bless her. The patient's fully aware of not to repeat this their mistake with the cotton bud again. And you can see all I'm trying to do now is just lift this off the canal wall. I'm just manipulating it and going to go all the way around. And it's sometimes earwax is like a game of Jenga. You pull out, once you pull out a certain block, it all caves in, and it's the same with this. So there'll be a moment during the procedure where I get a significant amount of wax out of this plug, I dislodge it, and then everything becomes it just falls into place afterwards. And it may even be this bar, I'm not sure. So we're on the anterior canal wall. This is right up against the eardrum. So we're on the medial part, the bony part, the sensitive part. So for the guys who've never watched my videos before, who have not heard the explanation of the anatomy. So if we average an ear canal length from the entrance to the eardrum, and this is an average in adults, to be around 3 centimetres now, you can then subdivide the ears into thirds. So the outer third is cartilaginous. It's made of cartilage, it's flexible. It's, I would say, semi-sensitive. You can put some pressure on there without it being uncomfortable for the patient. And we've got a thick layer of skin there as well. It's about 1 millimetre in thickness. Now, so that's the outer third. The inner 2/3 is the bony part of the ear canal. Now that's really sensitive, and it's just lined by a very thin, delicate layer of skin, and that's about 1/10 or 1/15 of the thickness of the skin that lands the outer third. So we're looking around 0.1 millimetres in thickness. And believe you me, if you make a contact with the bony part of the ear canal, it's not a nice sensation. How can I kind of translate that? I don't know, sometimes you've had a nerve exposed in your tooth and you have an ice cream or something cold. It kind of really shocks you. It's that kind of acute pain. And you can almost, I wouldn't say it's I'm trying to make a comparison of another type of pain that one can, or all of us can relate to. But I think that's probably the most, that's the only one that I can come up with. And you can imagine that's not a very comfortable experience. So I'm just trying to now bring it down from the top part of the ear canal. Because it's really impacted, the surrounding ear canal has become slightly inflamed, and when the surrounding ear canal has become slightly inflamed, it somewhat engulfs this plug of wax. There's so much tension and pressure in here at the moment. And again, by removing the core of the wax, the middle part, or just dissecting it, you're in a way releasing that tension, which then does help remove the wax. You can see there's a few hairs that are matted there. And just throughout the procedure, I was just asking the patient whether it's comfortable. A few occasions I did find it slightly uncomfortable, but I did explain to the patient they just have to somewhat grin that because I'm just being as gentle as I can anyway. And of course, they were already feeling a bit of discomfort prior to attending, so I wouldn't say there's any additional discomfort. And that just comes with experience. You just got to have trust. And at this stage, some people might have given up and said, look, go away, use some more drops, come back. Now the drops, patient going away using drops, now they had been using drops, but they were saying the pain increased tenfold because when you've got this amount of wax, yes, drops just soften it, just help sometimes remove it. But in that interim period, this plug of wax is going to absorb the drops and expand and swell and create more of a blockage and more pain. And so if I got the patient to go away and come back, it would have been really painful for them whilst they're using the drops. So we just persevered, and I knew deep inside this was going to come out. You just know. It's very seldom that I'm not now able to remove wax on the day. I would say in the last year, probably a couple of cases. I had one I wouldn't even say that one was a case. It was a case where they had keratosis obturans, and it was they were in that much pain. I asked them to come to the clinic just so I can evaluate their ear because they were that distressed. And I did say to the patient, it's very unlikely I'll have time to remove any blockage back, and just quickly examine it so I can, because they went elsewhere and it wasn't successful and they were in a bit of a panic. And I gave the patient some advice to use sodium bicarb and got the patient back in. And the other one was a very young child, I think she was 4. And bless it. It was similar to this actually, hers. It was really impacted. Parents had unfortunately used cotton buds and impacted against the eardrum, and it was very similar, but now with the child, obviously they're less cooperative and we didn't want to take any chances there. Sorry about this little blackout, probably forgot to just edit that out. And I've just got the patient, obviously, just got the child's parents to put some drops in. It was rock solid. It was much more harder than this. It was like stone, and it was right up against the eardrum. And that's the only 2 I've had all year, so I'll probably say only 1 this whole year. Now, when I first started, I would probably call back patients more regularly. I wouldn't say it was 100% success rate. And anyone that says that they're telling you a porcupine. They really are. But as you get more and more experience, it's very seldom now that I'm sure in the future I will have to still call some patients back, but it's a very rare event at the moment now. And that's because you develop the skill, experience, knowledge, and that just comes with doing more and more procedures. So remove the blockage, the eardrum's intact. You can see the medial part of the ear canal is all red. It's slightly tender, slightly inflamed because of the impaction. Just some dead keratin in the inferior recess there. So we're just mopping up. I did a pressure test just to check the mobility of the eardrum because it was slightly inflamed, just to make sure there's no glue here. That was fine. Patient could hear so much better post-procedure. I'm very, very grateful. So again, just mopping up around the edge. Well, thank you for watching, guys. I hope you enjoyed that procedure. And once again, I just want to thank you all the loyal fans, subscribers, supporters for